السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. أنا الدكتور صبري محمد مريم. بيشرفنا وبيسعدنا في هذه الليلة المباركة من ليالي رمضان المبارك، وعبر منصة المؤسسة المصرية لأطباء الأطفال أن أقدم أخي الكبير وأستاذي الفاضل البروفيسور محمد طلال الرفاعي من وطني الحبيب سوريا عبر منصتكم الكريمة. الأستاذ الدكتور محمد طلال الرفاعي بورد عربي في طب الأطفال، بورد أمريكي في طب الأطفال، حائز على شهادة البورد الأمريكي في الأمراض العصبية عند الأطفال. اسم معروف على مستوى مملكتنا الحبيبة المملكة العربية السعودية، مدينة الملك عبد العزيز الطبية، الحرس الوطني، بروفيسور الأمراض العصبية. مشرفنا ومنورنا يا دكتور طلال. ألو.
الله يسلمك.
بيسعدنا وبيشرفنا نقدم حضرتك، والميكروفون معك وكل الوقت معك. إن شاء الله النقاش حيكون بعد المحاضرة، وأنا كل ثقة أنه المحاضرة حتكون أكثر من رائعة. من الآن أنا عاجز عن الشكر، أنا وكل الزملاء في المؤسسة المصرية لأطباء الأطفال. تفضل أستاذ محمد.
جزاك الله خير. شكرا محمد. Good evening, ladies and gentlemen. Good evening, my colleagues in Egypt and Syria, my beloved countries. And first, I thank the organizers for inviting me to give this talk this nice evening. And I thank Dr. Muhammad Talal and Dr. Sabri Mariam for the nice introduction. And as you can see from the title, my topic will be on childhood headaches. And why I choose this topic, because I think it's important for both of us, for general pediatric, as you are the gatekeeper for those cases, because they will come to you, and then they will be referred to us or be consulted as inpatients as well. My talk will be divided into two parts, as you can see from the title. When to worry, which is basically I will talk about the secondary causes of headache or the secondary headache, where the headache is a symptom of an underlying disease. And I will discuss like the different red flags that should trigger investigations for underlying etiology, and then the schematic approach for such a presentation. And the second part, I'll talk about the primary headache in children, where the headache is the disease itself. And I'll discuss basically the common one, which is the migraine, and followed by the tension type headache, and then shed the light on others as well. I start my first part with illustrating case. A case 12-year-old boy, previously healthy, present as chief complaint of headache. This started 4 months prior to his presentation. It was mild, tension-like, left-sided, with a duration of 1 to 2 hours, frequency of 1 to 2 per week, and responsive to acetaminophen. Last 2 weeks prior to presentation, the headache became more severe, still tension-like, left frontal, daily, awaken him from sleep on 2 occasions, worsening with cough and defecation, and associated with double vision and occasional photophobia, phonophobia, and tinnitus. On exam, this is the growth parameters. As you can see, he's overweight with BMI of 31. On exam, he was alert looking. He has left esotropia with restriction of the left eye movement to the left with diplopia, indicating a 6 nerve palsy on the left side, and bilateral elevated disc consistent with bilateral grade 1 papilledema. Before I proceed with this case, I will go into the assessment of headache. So the purpose of assessment of the headache assessment is to first and foremost is to identify secondary headaches. Although the primary headache is much more common, still those secondary headaches need to be identified, especially looking for those rare serious ones, okay, that can have potential morbidity and mortality, and making diagnosis and starting therapeutic approach as soon as possible. And then make diagnosis of primary headache and optimize treatments, both abortive and preventive, and proper education and explanation and counseling of the family and the patient. So what are the available assessment tools? History taking, I think this is the most important one. Headache diary can be very helpful and can help us also on the monitoring treatment and monitoring triggers, as we'll discuss later. And physical exam is important, and investigations as needed. So the history with the key elements at the age at onset of headache, and for how long the headache is going on. So we ask usually the patient, when was your first headache? And then from then till the present, we ask about the course of the disease, the duration of each bout of headache, the frequency of headaches, and the onset to peak time of the headache, the location, generalized or unilateral, pain severity. Frequently, we ask the patient to grade it from 1 to 10, where 1 is the mildest headache ever, and 10 is the most severe. So we ask the patient to try to put a score for his headache if possible. And then the character of the headaches can be helpful, like throbbing pain, dull aching, pressure light, or stabbing. All these features we need to ask about. And then we ask about the pre-ictal phase of the headache. So prior to the bout of headache, did the patient has any symptoms? Like in migraine patient, they have alarming symptoms, like patient becomes moody and irritable, and having like tightness in his neck or his head. And then if there's aura, which basically a neurological symptom that is transient, okay? This can happen in some patients with migraine with aura. The course of headache is very important to get from the history. And you can see in this figure, we have different kind of courses of headache. The first and the last one are the most severe ones. So the first one is the thunderclap headache, okay? Or headache that's worst headache in patients' life. This is frequently they describe this as this is the worst headache in their lives. And on the axis, the x-axis is like the duration of the headache, and then on the y-axis is the intensity of the headache. As you can see, this headache is intense from the beginning. So from the first few minutes, the headache reaches its maximum, okay? And so this is worrisome, and this is usually present with patient who has ruptured blood vessels, like intracerebral bleeds, patient who has vasoconstriction of cerebral blood vessels, patient who have acute infection like meningitis or acute hydrocephalus. All these can present with this kind of headache. So as you can see, it's like really a dangerous type of headache that really need emergency like attendance. And then the last one, which is basically the headache that start mild and infrequent and become gradually worse in frequency and intensity. And this is usually indicating a building up process in the brain, especially high ICP, like masses or hydrocephalus or pseudotumor cerebri, as we'll discuss later. The second one from top, which is the migraine course. Usually it's headache, severe headache, that comes in attacks, and in between the patient has a headache-free period, can be long or short, but the patient is completely normal in between. And the headache, as you compared with the first one, has a crescendo at decrescendo and decrescendo like figure, where the headache gradually get intense until it reaches maximum, and gradually it fades away. So this is the typical for the headache attacks on migraine. The third one, which is the chronic daily headache, usually tension-like, where the patient has dull aching headache, not severe, but it's like most days of the month, and we call it chronic daily headache. Sometimes this can be associated with migraine as well. So you have bouts of migraine, severe attacks, and then in between there's mild aching headache that's present. So frequently you have to ask the patient if they tell you that they have headache, you have one type or more than one type, and then ask about the frequency of each one. The last one here, like the fourth from top, which is basically the typical for the cluster headache or the trigeminal autonomic cephalgias, where the cluster headache is the prototype. where the headache comes in bouts, where each bout has many attacks of headaches that are short-lasting, and they are very severe in intensity. And in between these bouts, the patient has a long period of headache-free. And according to the course of headache, we have some differential diagnosis. I think it's good to bear this in mind. The one that I colored with the green are the common ones, and the one that are red are serious ones. That they are rare, hopefully. The acute headaches, so new onset headache, patient was completely free before, and he has new onset headache. This is usually a secondary headache until proven otherwise. It's a benign cause, like acute febrile illness, like flu, or in the area of COVID infection, sinus infection, dental infection. So these can present with acute headache. More rare ones, but they are serious and they should be kept in mind, especially patients who are working in the ERs. Intracranial infections like meningitis, inflammation like vasculitis, bleeds like intracerebral bleeds or subarachnoid bleeds, trauma and signs of trauma, hypertension, stroke, systemic diseases that predispose for hypoxia or hypercarbia. They can present with acute headache. And in a scenario of like exposure to carbon monoxide, we should think about carbon monoxide poisoning, where the headache can be the sole presentation. Acute recurrent migraine is the prototype and the most common, but others related to mechanical causes mainly, you can see it with intermittent hydrocephalus, especially if there's obstruction, and then Chiari malformation and epilepsy in rare cases. Chronic progressive, usually it indicates high ICP until proven otherwise, with the differential diagnosis of masses, hydrocephalus, venous obstruction, and idiopathic intracranial hypertension or pseudotumor cerebral. And also the chronic non-progressive headaches that will be going on for a long time, and the patient still the same, still active, still doing like his daily activities, no other new like symptoms or signs, is really seen with tension type headache, with psychogenic headache, post-concussion syndrome, and ocular refractory errors. Key elements in exam, I think it's important to look for the vital signs, especially blood pressure, hypertension, head size, even older patient. Big size of the head may indicate findings, or abnormal head shape, patient who have craniosynostosis. And by the way, craniosynostosis, even like isolated craniosynostosis, may present sometimes with high ICP. So keep in mind the looking for the head size and shape, body weight, neurocutaneous stigmata, indicating neurocutaneous disorders, systemic signs and or illnesses like joints or fever, joints pains, or inflammation or fever, tenderness, scalp tenderness, especially in patients who have tension type headache, allodynia that you see with headache that persists for a long time, and palpation of the sinuses can give you a clue about an underlying sinus infection that needs attention and treatment. Examine the neck for stiffness, and examine the thyroid for the size of the thyroid. Neurological exam, especially pay attention to the mental status, the patient with behavioral changes, confusion, personality changes, or school difficulties lately. All these can be a sign of like cooking intracranial pathology. Focal deficit obviously indicates a focal lesion, and then papilledema, which can be sometimes the solo finding that you may see in patients with high ICP. So these are the red flags. Red flags is taken from adult literature, like the Snoop. Snoop is like to look secretly on others, on other people's matters. So Snoop. And in children, it was added the Y because of young age. So it becomes a Snoopy. Okay? So the S stands for the systemic symptoms and diseases. So presence of patient with headache and fever, with recent weight loss, high blood pressure, patient who has recent trauma, patient who have history of VB shunt or history of tumor or malignancy, immunosuppression, tendency for bleeding or thrombophilia, growth abnormality. All these may point to an underlying cause that has a new finding with headache. Neurological symptoms and signs, as I mentioned before, change in the level of consciousness, a change in personality, change in behavior, recently poor schooling, something that's not usual for the patient. All these points toward the pathology that's getting worse with time. Acute change level of consciousness, like increased somnolence or lethargy, which also can be seen with acute presentations like infections or inflammations. Seizures, obviously, indicate it's a surrogate for disease of the cortex of the brain and indicating pathology. Neck stiffness with irritation of the meninges and infections or subarachnoid hemorrhage. Papilledema with high ICP or various causes. And persistent focal signs more than 1 hour. And this is for more than an hour because most of the auras that's seen with primary headache, they last less than 60 minutes. So persistence more than 60 minutes, it may indicate that this patient has a disease, a secondary disease that's evolving. The onset of headache, recent onset headache, as I mentioned before, it's an indication of etiology. As mentioned, can be benign as infection or sinuses, or it can be serious as CNS infection or bleed. A sudden thunderclap headache, seen usually again with patients who have ruptured blood vessels in the brain, or intracranial cerebral hemorrhage, or IVH, intraventricular hemorrhage, or even subarachnoid hemorrhage. Patient with CNS infection can have this type of headache. Patient with hydrocephalus, a patient with venous thrombosis, or patient who have sometimes vasospasm or reversible cerebral vasospasm can present with thunderclap headache as the main symptom. The occipital location, if it's persistent occipital location of the pain, severe pain, I think should be kept in mind as potential serious pathology like the tumors. The pattern of headache, and here we have 4 Ps, precipitation by Valsalva maneuver, like cough and sneeze and straining. Positional, so worse with lying down indicates high ICP. Worse with standing up or sitting up indicates more of intracranial hypotension that you see with CSF leak, especially after LB, after spinal tap. A progressive headache, as we mentioned before, you get progressing pathology like a tumor or hydrocephalus or pseudotumor cerebri. Lack of family history in the parents, although many patients with migraine have family history, still there are some group of patients with migraine, they have lack of family history. But before you label somebody as primary headache, if he has lack of family history, we have to pause before we label him. Young age, and this is chosen because patients younger than 6 years, especially younger than 5, they have difficulty in expressing their symptoms and clinical findings. So we have to be more careful in those patients looking for underlying etiology. So relative red flags. So not all red flags are equal. So systemic diseases, for instance, systemic findings, neurological deficits, they are more serious than somebody who has only a occipital headache. But it can be considered, if it's persistent, as occipital headache and severe, should be kept in mind as one of the red flags. Fixed laterality, meaning a headache that comes all the time in one side. We should, like in those patients, look into an underlying pathology, especially AV malformation that can give you sometimes migraine-like headache, but usually it's unilateral to one side. It may help in some of those patients to listen to their head with the bell of the stethoscope, especially put it on the closed eye and the head, and looking for any bruise or murmurs, which can be diagnostic for those cases. We talked about family history, lack of response to medical therapy, headache duration of less than 6 months, although it can be primary headache, but we should also, again, pause and think about other causes before we label somebody as primary headache. And as I said before, difficulty getting information from patient or family sometimes can be a red flag that may warrant further workup if we are not sure. So other tools for diagnosis. Neuroimaging is the main one, and especially CT or brain MRI with and without contrast. CT is readily available in ERs, but MRI is more sensitive and has obviously no radiation and exposure to radiation. We look for the neuroimaging for any pressure signs like ISAP features or hydrocephalus or tumors, evidence of infection or inflammation, looking especially for that's why contrast is important. We look for hemorrhages. We look, sometimes we may find things that we were not expecting, and it becomes sometimes difficult to relate these incidental findings to the headache, and then it may create an anxiety on the family and may require further assessment for those patients. A spinal tap when needed. So if they have high ICP symptoms and no clear findings on neuroimaging, then spinal tap is imperative to look for pseudotumor cerebri, looking for subarachnoid hemorrhage if the CT is not showing evidence, looking for xanthochromia and RBCs, and then findings of an infection or inflammation with pleocytosis and doing some lab or with cultures or PCRs looking for underlying organisms. So we go back to our case. So the patient has, as you may remember, they have history that becomes worse lately with features of high ICP, of papilledema, and 6-nerve palsy. So a differential diagnosis for such case would be intracranial mass lesions, like tumors, obstruction of venous outflow, like venous sinus thrombosis or jugular vein compression, and then active hydrocephalus. And then if these are ruled out, pseudotumor cerebri is the potential diagnosis. So CT scan was done in the ER and it was normal. LP was done, which showed opening pressure of 38, as you can see. CSF count was remarkable for very mild pleocytosis, but the culture were negative, and the meningitis panel multiplex for PCR was negative. The brain CTV showed, as you can see here, like the arrow, there's evidence of thrombosis of the left jugular vein bulb. Further workup showed patient to have mild increase in the PTT and decrease in the platelets. Further workup for thrombophilia, there was positive lupus anticoagulants, and patient has final diagnosis of high intracranial pressure due to jugular vein thrombosis due to antiphospholipid antibody syndrome. And patient was treated with acetazolamide and anticoagulation for a short period, and patient did well. Case number 2 is a 7-year-old boy with ADHD on Risperdal, headache for 1 year off and on, frontal and occipital, throbbing in nature and moderate in severity, has frequency of 7 times per month and no change in the last year. He was treated as migraine with riboflavin prophylaxis, and the frequency, in fact, decreased to 2 per month. However, 2 months earlier to the presentation, his headache became daily. It was frontal and occipital. It affected his sleep. It was dull in nature and responds partially to painkillers. He had associated symptoms of dizziness and vomiting into occasions, and it was provoked by cough or sneeze. And also he has some electrical shock feeling when bending his head over, and occasional numbness in his left hand. So as you can see, the patient developed symptoms that are associated symptoms that pointing towards something different. So MRI was done. The positivity on this MRI, this is the foramen of magnum level here, and you can see that the vermis, the cerebellar vermis, is displaced down about 5 millimeters or more, and the diagnosis of Chiari malformation. So the patient underwent decompressive surgery and 3 weeks later was doing well with significant improvement of headache and off and on mild headaches, but no more cough-related headache. So a clinical consideration for this case, as you can see from our presentation initially, secondary headache can mimic primary headaches. And this is why it's important in primary headache. In fact, it's one of the mandatory criteria of primary headache is a headache that's not can be accounted by something else, okay? So migraine headache that can be related to AV malformation, for instance, it's not called migraine, although by history and by findings, it looks like it. So primary headache sometimes or the secondary headache can mimic the primary headache. Occipital headache is persistent, is a red flag. And headache that provoked by the Valsalva maneuvers, like cough, sneeze, or straining, is a clue that the relation of the headache in this case was related to chiari malformation. As I said before, sometimes doing neuroimaging and MRIs on those patients with headaches, frequently you may encounter an incidental finding. And one of them is, in fact, is the chiari malformation. Frequent chiari malformation is discovered by chance by doing MRI for another reason. Like we see it frequently in patients who are, we do MRI for epilepsy, for instance, or for seizures, and then you get chiari malformation, and obviously it's not related to the seizures. But if you do it for headache, then it becomes difficult to sort out if the headache is related to the chiari malformation or is an incidental finding in a patient who have a primary headache. The clue for that, if the headache is occipital and precipitated by Valsalva maneuver, it's most likely it's related to the chiari malformation. Otherwise, our surgeon would prefer to wait on those cases until further proof that the chiari malformation is relating to the headache. Case number 3, a 12-year-old girl, previously healthy, started to have headache for the last 3 to 4 days. They are severe enough to awaken her from sleep, and they are pulsating in nature in the frontoparietal area with extension to occipital and right temporal areas. It's continuous, not relieved by sleep or analgesia. She has associated findings of nausea, dizziness, and decreased oral intake lately, and activity and decreased activity and photophobia. On exam, she was alert, no focal deficit other than elevated disc bilaterally. By ophthalmology exam, it showed bilateral papilledema grade 1. CT brain and the brain MRI and MRV were normal. CSF opening pressures was 52. The CSF contents of cell count, protein, and cultures were all normal. A patient has in her lab enough evidence of severe iron deficiency, anemia. So diagnosis was pseudotumor cerebri associated with iron deficiency anemia. The patient was treated with acetazolamide and iron supplement. 4 months later, no more papilledema, acetazolamide discontinued, and she continued to have off and on mild tension type headache, which were infrequent. And at 1 year afterwards, she was discharged from clinic because she was doing well, and her eye exam continued to show no evidence of recurrence of the papilledema. So pseudotumor cerebri, this is like very important topic to bear in mind whenever you encounter a patient with headache. And why it's important, not only because the headache can be debilitating and severe, but we care more about the visual loss, because some of these patients, if they lose their vision, it becomes like permanent and non-reversible. The risk factors is usually obese adolescent females. Treatment is usually with acetazolamide. In rare cases, we can add Lasix or use topiramate in somebody who did not tolerate the acetazolamide. And in rare cases, you may need to go for surgery with lumpoperineal shunt or optic nerve sheath fenestration to relieve the pressure and avoid the visual deterioration. These are like some causes of secondary intracranial hypertension, and they can be associated with pseudotumor cerebri. Medications, there's a big list of medications. The most important one of them is like the vitamin A analogs, the Roctan and others. the steroid treatment, and also titration of steroid, rapid titration of steroid may lead to that. Tetracyclines, anemia, especially iron deficiency anemia, patient with Guillain-Barré, patient with renal failure, systemic lupus, trisomy 21, vitamin deficiency, D deficiency. These are cases or diseases that can be associated with pseudotumor cerebri and need to be kept in mind and looked for in somebody who has this presentation. Case number 4, and this is a 9-year-old girl with headaches for 4 days. Headache left temporal region, moderate, ophthalmology exam, bilateral papedema. The patient was sent to ER from a ophthalmology clinic. The ER brain CT was normal. LP was done and showed opening pressure of 30, and the content of the CSF were normal. So the provisional diagnosis was pseudotumor cerebri, or the other name for it is idiopathic intracranial hypertension. But usually before we start treatment with acetazolamide, usually we do vascular neuroimaging, particularly via CTV or MRV, to look especially for venous thrombosis. But in this patient, we did not find venous thrombosis, but we found, like, interestingly, abnormal blood vessels, like looks like worms, as you can see it, and it's proven to be with MRI as AV malformation. As you can see, these like abnormal blood vessels. It's a big, indicating a big AV malformation on the left side of the brain. So this is a very rare and unusual representation of AV malformation presenting as picture of pseudotumor cerebri. This is something that has been reported frequently in adult literature, but not in pediatric. So large AVMs, because of the big shunt of the blood from arterial to venous, leading to high intravenous pressure, this can predispose for the pseudotumor cerebri. Of course, this patient was treated with acetazolamide, but if you don't treat the underlying pathology, probably acetazolamide will not work. So the patient underwent cerebral angiogram, and the feeding artery was embolized, and which led to the decrease of the shunt, and then improvement in the papilledema and the headache. And the repeat MRI later on showed no significant change of the AVM, but the features of pseudotumor cerebri resolved on follow-up exams a year or more afterward. So clinical consideration in this case, so AV malformation, especially large ones, can present with pseudotumor cerebri picture. Vascular imaging is imperative in patients who have presentation with pseudotumor cerebri in order specifically to rule out venous thrombosis, because using diuretics sometimes may be risky on those patients, and the treatment with anticoagulation is the standard of care. So take-home messages from this part of the talk. Try to look for papilledema, and I always encourage the residents and the general pediatric residents to learn how to look on the fundus. Okay, it's very nice skill that you can develop if you do frequent ophthalmoscope exam, especially if you have the luxury to buy those ones that are the panoptic ophthalmoscope, which can give you better view. I think discovering papilledema early, that sometimes you may save some patients from deterioration of vision if they are young enough or they did not have enough symptoms early in the course. Secondary headache can share features with primary headache, so we have to bear this in mind, and to remember the SNOOPY acronym for the secondary headache in children. And not all red flags are equal, as we said. Some red flags are more serious than others, as we discussed before. Secondary headache, not always serious. Most of the time it's benign, but in rare cases it can be serious with potential morbidity and even mortality. And those are the cases that we cannot afford to miss. So this is the end of my first part. And before I will go to the next part, I will just take a moment to drink a sip of water.
صحة وهنا، صحة وهنا دكتور محمد.
Thank you, Dr. Sabri. Okay,
ابشرك
I'll move.
ابشرك اجت الكهرباء، بس مشان نعمل بريك اعلاني نريحك شوي.
Okay, thank you very much. Good to hear that. Good to hear
Yeah.
that, Dr. Sabri.
Please.
I'll move to my second part of the talk, which is the primary headache and primary childhood headaches. The International Headache Society, they have classifications that have different editions. The latest one was in 2018, and they are divided into primary headache disorders, including migraine, tension type headache, cluster headache, and other trigeminal autonomic cephalgias. Secondary headache disorders, and we talked about those in the first part. And then rare ones that are cranial neuralgias, like trigeminal neuralgia or occipital neuralgia, and others. And I'll start with the migraine, where the criteria is, as you can see, the patient needs to have at least 5 attacks lasting 2 hours to 72 hours. And characteristic of the headaches, you have to have 2 out of 4 here on the left side. So unilateral, pulsating, moderate to severe, aggravated by daily activities. So if you have 2 out of those, then you fulfill the criteria of the character of the headache. And then associated symptoms, at least one of the following: nausea and or vomiting, photophobia and phonophobia. Okay, so one of these two, plus 2 out of the characteristic headache. And then the last one here, it's important, as I mentioned before, is not better accounted by another diagnosis. Okay, so this is a criteria that you see in all the criteria for the primary headaches. So the migraine without aura, so that was the migraine without aura. Now the migraine with aura, it's similar to the migraine without aura, plus the presence of a transient focal neurological signs, particularly the visual signs, followed by sensory, and less frequently motor or speech and language. Usually the aura in migraine is gradual onset, does not reach maximum quickly, so it's gradual, and it takes a few minutes, 5 minutes up to 1 hour. After 1 hour, I think you should start thinking about other things like ischemia, especially transient ischemic strokes or attacks. And then before 5 minutes, you may start thinking about like seizures. But the typical duration is the gradual onset of motor, focal deficit that lasts anywhere between 5 to 60 minutes. This is like the aura that was described and depicted by the patient themselves. As you can see, it looks like zigzags, shapes, light, bright dots, colored dots, haziness. All these are like symptoms that are reported by a patient who has migraine, which is the most common type of aura that you may encounter. Sensory ones are as well, especially like feeling sensations of like pin sensation that's moving from one area to the other. And then we have to, in those patients with migraine, it's usually the headache of migraine is precipitated by external factors, and stress is one of them. Missed meals and long fasting, poor sleep hygiene, dehydration, dietary factors are there, but usually they are not frequent. Frequently identified. And then menstrual cycles in childbearing age in females. Others, relaxation after stress, bright lights, loud noise, special smells like perfume, minor trauma to head and neck, and exercise in some patients. So the management of migraine, we have general measures, we have abortive treatment and prophylactic treatments. So the general measures. First and most important is education of these of the family and the patient himself. So describing the nature of the illness, assure them that this is, yes, it's annoying type of headache, it's painful, but usually they are not harmful. Okay, and we also educate them about lifestyle modification in order to lessen the frequency of the headache, especially assuring good sleep hygiene, like getting enough sleep, 8 to 10 hours. And I tell them also before they go to sleep not to have any exciting like devices or TV or anything that make them excited and then affect the quality of sleep. During the day, to drink enough water and to eat regular meals, especially in school. Children, ask them to eat the breakfast before they go to school, because a mild drop in the blood sugar and fasting may lead to provocation of the migraine attack. Exercise from adult studies show that routine exercise, especially 30 minutes 3 times per week, has lessened the frequency of headache. Headache diary is also important thing to utilize, because it can give you like more information while the headache is occurring, and the patient will pay more attention to details of the character of the headache and associated symptoms, as well as type of food that was eaten during that time of the headache or prior to the headache, and also to monitor therapy, okay, and the treatment, okay. So after they come to the clinic with headache diary, you can look if their headache frequency is getting less and the intensity is getting less, so that indicative of probably your therapy is doing the job. Identifying precipitating factors like caffeine or certain foods that may provoke the headache. Some people, they are provoked to headache by certain foods, like all the cheese, like yogurt, and others, and chocolates. So identify precipitating factors can be helpful in order to avoid in the future to avoid precipitation of the headache. This is like an example of headache diary. It's like in the internet by the Children's Hospital of Boston. Abortive therapy. The general rule for abortive therapy is to start as early as possible. If you wait until the patient has reached maximum headache, then it becomes difficult to abort the headache. It's important to give enough dose of the medication, and make sure that patient try to get to sleep and relax and get to sleep, because sleep frequently will lead to abortion of the migraine attack. And then beware of over-medication. So using painkillers may lead to headache overuse, medication overuse, and then we have to be careful about that. So in patient who takes acetaminophen, as I said before, or later in treatment, taking it more than 14 times per month, or the sumatriptans more than 9 times per month, may lead to medication overuse headaches. So according to the practice parameters by the American Academy of Neurology and American Headache Society, they reviewed the evidence and the studies done on abortive treatments, and they come up with a recommendation. There is strong evidence for acetaminophen and ibuprofen for treatment of headache as a first line, and triptans, several triptans have evidence from randomized trials to be effective. Not all of them has evidence, but all of them, they are used, because probably they are all of them equally effective. Naproxen has been used and it's effective. Aspirin probably should be avoided because we have alternative, and there is risk of Reye syndrome in children, so try to avoid it. In severe cases that did not respond to the first and second lines, IV ketorolac is one option. antiemetics for vomiting and severe nausea, and dihydroergotamine for refractory cases. Okay, so this is a medication that can be used in really refractory cases that prolonged headaches that did not respond to all these therapies. It's good to have a pathway for treatment of headache in your center or your practice, so to unify the management and in order not to miss things, especially like patients who come to the ER or people who are practicing in ER. In our protocol, the patient is triaged using existing ED triage protocol, including initial stabilization. The staff physician in the ER will conduct history and physical exam, and the features that they look for, we discuss it. The red flags, the headache triggers, medication used and doses and frequencies, the vital signs and complete neurological exams, and signs of infections, infectious disease, trauma, or rheumatological disease, and exclude any red flags by history and examination. And we mentioned in the pathway the red flags, and I mentioned them before, but we collected them, as you said before, in the acronym of SNOOPY, but they are written and available for the IR person to look for. And then when to refer to neurology, if the patient has red flags with initial assessment and ancillary tests not revealing, then neurology can be consulted. And if there's no sufficient improvement following the first-line therapy, then neurology can be involved in those cases as well. So what is the management protocol? IV hydration is very helpful. Frequently, those patients who come to the ER, they are in severe pain, they have poor PO intake, or they have nausea. And then giving IV hydration can be very helpful. We try to make the room for those patients quiet and with dim light and allow them to get rest and sleep. And we can use pharmacological treatment with first-line ibuprofen or acetaminophen with good doses of 10 milligram per kg, the ibuprofen, and 50 milligram per kg for the acetaminophen, and monitor the response. If there is no response to one, you can use the other one. Okay, and then if both did not lead to improvement, then we go to triptans. The one that we have and we use in our hospital is the somatriptan. We have the nasal and we have the sub-Q injections. Well, these are the doses, 5, 10, and 20, according to the age. And the patient can be discharged when asymptomatic for 4 to 6 hours. We can review with the patient the healthy habits, do education if you have the luxury of time in the ER to do that. Otherwise, we'll do it in neurology clinic or general pediatric clinic. Obviously, it can be done. And the patient, if he's known to neurology, will be given appointment within 2 weeks. And if it's not known, a referral in the system will be put and the patient will be seen within 4 weeks. So this is the protocol that we use. It unified treatment and management in the ER. Prophylactic treatment. Okay, when we resort for prophylactic treatment, usually patient has frequent headaches. And frequent, if you have at least one headache per week or more, that's an indication high frequency of the headache, and then this is an indication. Headaches that are really severe when they come, persist for a long time, they are leading to significant dysfunction and visits to the ER and absence from school, then these are the ones that can be candidate for prophylactic therapy. These are the drugs that used for a long time. We have cyproheptadine as antihistamine, serotonin. We usually use it for like young children. Propranolol is used also for young children. Amitriptyline for older children or than 12 is what we usually do. Other medication, flunarizine and flunarizine and cinarizine also have some evidence. valproic acid and topiramate, also some studies to support them, and as well as some studies, retrospective studies, not strong evidence for riboflavin and coenzyme Q10. The review of the American Academy of Neurology and American Headache Society, in their publication 2019, there was evidence that propranolol, amitriptyline, cinnarizine, topiramate, these are the ones in red font. They have some evidence that they are better than placebo in studies. However, the placebo effect of most of the studies, randomized trials, showed very high positive effect for the placebo, anywhere from 30% to 61%. So many times the placebo is equally effective to the drugs. Okay, so the trials, the first drug that was approved by FDA in the United States for treatment for prophylaxis for headache in children was the topiramate, according to the study published in 2009, where the high dose 100 milligram per day was more effective than placebo, and the lower dose 50 milligram. So it was approved. However, the CHAMP study that was published in 2017 in New England Journal was having like very stunning results, where the amitriptyline, topiramate, and the placebo were all equally effective. Okay, amazingly, amitriptyline was effective in 52%, really the improvement in 52% of the cases, topiramate in 54%, and placebo in 61%. I mean, the numbers are higher for placebo, but statistically not different. So the study has to be stopped. And later, the latest systemic review for this topic showed that there's short-term benefit of topiramate and propranolol for treatment of migraine headache. Before this study, the CHAMP study that's highlighted here, we used to frequently use propranolol and cyproheptadine in young children, younger than 12, and amitriptyline above 12 years of age. But after the study, we shift the gear toward using other drugs that are, we call it, they are more of labeled as food supplements like riboflavin and coenzyme Q10 as first line in those patients, with good education for the patient and give them positive attitude about the illness, and engaging them in the treatment, including the lifestyle modification that we talked about, plus adding one of these drugs that have very low side effect profile. For riboflavin, there's minor side effects, like occasional patients have some GI issues. Some of them, or most of them, they have some change in the color of the urine, but it's not harmful. Frequently, they tolerate the medication. And I would say about 70 to 80% of the time, we get improvement when they come back to our clinic. We start usually 5 milligram per kg or more than 20 kg. I start with 100 and increase it after 1 month to 200 or 100 BID if the patient did not improve. We maximum reach for 400 per day. Same thing for the coenzyme Q10. One caveat for coenzyme Q10 to be used in the morning because it may cause insomnia given in the evening. But other medication can be used as well. Sometimes I add cyproheptadine to riboflavin if the patient is, let's say, he is poor eater and he is young child, he's thin, so cyproheptadine can be used. It has also the positive side effects, which is improving the appetite, so it can be used as well. Propranolol can be used as well in patients, but to have to be careful in patient who has diabetes and bronchial asthma, and we have to monitor blood pressure, especially looking for hypotension when they come to the clinic. Do hypotension, looking for especially orthostatic hypotension. For the anti-epileptic drugs, we leave them for the patient to have comorbidity of epilepsy, or those rare cases that are intractable chronic daily headache. Okay, we can use these drugs, especially topiramate. But this is how we practice. Behavioral interventions, whenever available, it can be very helpful. It's usually involve cognitive behavioral therapy, which teaching the patient relaxation techniques and stress coping and adjustment and coping with the disease. Sometimes some trainers, they have biofeedback training, and then it can help as well. The randomized trial showed benefit of this modality, but only when it's usually added to the amitriptyline. So usually it's helpful in teenagers with headaches that did not respond to first-line prophylaxis, and it can be used in addition to amitriptyline. Tension type headache, and this is a headache that's usually dull aching headache, 10 episodes. You need 10 episodes of those headaches to fulfill the criteria of society. Duration between 0.5 hours to 7 days. At least 2 of the following: bilateral, tight pressing, not pulsating, mild to moderate in intensity, not activated by routine activity. Both of the following: no nausea or vomiting, no photophobia or phonophobia, no photophobia and phonophobia, but you can have one of them is okay, and not accounted by other diagnoses. Frequently, those patients, they have tightness of their scalp muscle, and then you can, when you palpate those muscles, you can feel tenderness to palpation. Management, similar to migraine, alleviate stress, because stress is like big time work on those patients to worsen their headaches. For acute headache, ibuprofen and acetaminophen. For prevention, lifestyle modification is important, amitriptyline, and less frequently topiramate, and behavioral therapy similar to migraine. A chronic daily headache, any headache that lasts more than 15, comes more than 15 days per month, more than 3 months. After excluding other red flags, it can be like under this category. One thing that may come sometimes, which is the drug overuse headache, can have the characteristic of chronic daily headache. So we have to look for those and try to avoid them by reducing the use of the analgesics, as we discussed before. The last part of this talk will be about the trigeminal autonomic cephalitis. It's like very rare disorders in children, include cluster headache, paroxysmal hemicrania, hemicrania continua, short-lasting unilateral neurology-form headaches. One of the things that you have to remember in this disorder is, first you have to do neuroimaging on those patients, because you need to rule out secondary causes before you label patient as primary. And then think about using indomethacin, because it's one of the criteria of diagnosis paroxysmal hemicrania and hemicrania continua, because those patients, they are sensitive to this drug and they improve. And it's, in fact, it's a criteria of the diagnosis. Criteria for cluster headache: 5 attacks, severe unilateral orbital, supraorbital, and temporal pain lasting 15 to 180 minutes, along with one of the cranial autonomic changes, like conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead and facial sweating, meiosis and ptosis, and sense of restlessness and agitation. Remember, migraine, usually patients, they are quiet. Those patients, they are more agitated and restless. And the frequency of attacks, anywhere between once every 2 days to 8 per day. So this is like cartoon to show you what are the symptoms. Paroxysmal hemicrania, similar findings, but they are like shorter in duration, and they are responsive to indomethacin. Take-home message. Please keep red flags in mind all the time when you are encountering a patient with headache. Learn to visualize the fundus. Headache for more than 6 months and still has normal neurological exam is unlikely to be serious. Severe recurrent headache in between the child is normal, is very likely to be migraine. Mild recurrent headache is usually tension type headache. And finally, suggest that each one in his center to have a pathway for those patients for acute management like in the ER, or you can create one for the chronic headaches. So you can unite treatment and therapy in your institution and your center. And with this, I finish my talk, and I think we are ready for questions and answers. Thank you very much.
السلام عليكم ورحمة الله وبركاته أستاذ محمد طلال.
وعليكم السلام ورحمة الله.
I would love to thank you about your comprehensive, practical, and wonderful lecture about the headache. And I think you have just covered all the points related to this important topic, headache in children. And I think you answer all the questions that we kept in our mind about this topic. But anyhow, I will give the chance for our colleagues to ask you about many points related to your lecture. Please, Dr. Talal.
Okay, I'm ready.
Okay.
Thank you very much.
دكتور محمد هلال، الأستاذ دكتورة مروة، دكتورة عايدة، إذا بتحبوا تشاركوا بعد إذنكم تفضلوا.
تمام دكتور طلال. Thank you for your beautiful talk, and we want to exchange our experience. Okay.
Thank you.
For children with headache, okay, we have many controversy about which type of drug to start as prophylactic, which is more effective, and how to choose the prophylactic therapy, and when to decide to give prophylaxis. Okay. So
okay,
this is very common question we usually asked by our colleague.
And this is a very valid question. I covered it, but I can elaborate more on this issue.
Yes.
As I said before this CHAMP study, we used to use cyproheptadine and propranolol in the young children before 12 years of age as first line. Unless patient has other comorbidity, like if he's obese, I would not use like cyproheptadine, and if he has asthma or if he has diabetes, then I would not use propranolol.
But what about its efficacy? From our practice, it is not so effective in termination of the attack of headache, and usually we need to add another anti-migraine as prophylaxis.
Yeah. So I was talking about this issue. Yeah. So it's interesting. And after the CHAMP study, you found that these big drugs, okay, used for many years, the amitriptyline and topiramate, they were as effective as the placebo. So I think it's very unique to children, the placebo effect of these drugs. So after this study, we adopted like more approach using less medication with less side effects. Okay, as I said, we use riboflavin most of the time. It's like our first choice, but with the medication, you have to involve the child himself. Okay, so first, when you talk to the child about the diagnosis, assure him that this is like a benign entity that will not harm him. It's annoying, but it's not harmful. It will not cause any damage to his brain because they are afraid that they have something serious. So when you assure them, you give them a positive attitude, and you make this, and you use this placebo effect, okay, to your advantage in improving his headache. And you can also dwell more on the other things that he has to do in his daily life. So usually what I will tell him, look, your headache is annoying, but it will not hurt you. We call it migraine. This is the positive thing. It's benign. And the treatment should be between you and us, okay? So we can help you with one thing, but you have to help yourself with the others. Okay. So what are these others? I tell them, okay, you have to go to sleep early, before sleep, and no devices like screens or TV, no exercises before sleep. So if you get like enough or good sleep, night sleep, frequently you will not get migraine next day. Okay, this is like general rule. The second thing, you have to drink a lot of water, okay, to avoid dehydration, and drink good amount of water. Okay. The third thing is to eat regular meals, okay? So especially the breakfast for children, and then do exercise, okay? Exercise improves the mood of the patients and also improve the headache frequency as in the adult literature. So once you put this child in this positive mood and start him on treatment, tell him I'm going to give you a medication that can help you. With this, I find that most of my patients, like 70% to 80%, they when they come back after 1 month or 2 months, they are much better. Okay, I think we have to be more positive when we talk about the migraine with the patient, and to involve the patient in the care and treatment of his disease.
Yes,
Right.
yes, very, very good. Okay. Some practice adding another prophylaxis. If we give the cryptopidine and the patient is not responding, after how much we decide to replace it by another or added another, which is more practical.
I think you have to like start with low dose and go up until you reach like maximum or side effects, and then you can switch, but you don't add. Okay. So unless I would add only in one thing, if the first drug that I use is riboflavin or coenzyme Q10, then these are like food supplement, then I can add to it like one of these drugs. But adding like say cyproheptadine to propranolol or propranolol to amitriptyline, this is not a practice that many people do. Okay, they will just switch from one to the other, but not combination. Okay.
Okay. After how much time you decide to replace? As you know, most patients.
Let's say like. Let's say I used like riboflavin, okay, like 100 for 1 month did not improve. I asked them to increase it to 200, 100 BID. Next time when they come, I increase it to 300, okay, after 1 month, okay. After that, you can either go to a 400 or you can switch at that time or add something else. So once you reach like maximum, so about like 3 to 4 months, usually I give a trial for these medications, okay.
Very,
like
very, very
general.
Yes, yes. Very, very good. For topiramate, many parents didn't accept the side effect, as you know, they affect the cognitive function, and many parents are have worry about academic achievement of their children. Debakine valproate now is added in the prophylaxis. Okay, according to your experience, which is better to start it as anti-epileptic? Valproate or topiramate?
Well, I mean, I try not to use either one of them. Okay, I usually anti-epileptics. Okay, especially these two drugs. They have like side effect profile that's usually not acceptable to me. Okay, to use it like, and rarely I use the topiramate for the chronic daily headache that did not respond to other treatments. Okay. But dipakine, I don't use it. I use it only if the headache is coexisting with somebody who has epilepsy. Okay, so if you have the choice and somebody has epilepsy and has migraine, because you know epilepsy, they have higher risk of having like migraine as well. Like they have 4 times. So I try to choose one of these two. Okay, but as a patient who has migraine alone, I leave them for the last resort. Okay.
Okay, in some practice, okay, some physician asking for EEG as part of workup for migraine and headache. I don't agree for that, but some doctors do that. And as you know, EEG may show abnormal discharge even in healthy persons. And based on this abnormal EEG, they decide to starting anti-epileptic as prophylaxis. What's your opinion about this practice?
Yeah. So 5% of the population or kids, they have abnormality on the EEG.
Yes.
So in headache, I think it's not, it's not a good indication to do EEG on patients who have headache, okay? Because as you said, you'll find these abnormalities, especially in migraine, okay? Frequently they have some spikes in their occipital area, and they never have epilepsy. So I would not do EEG in patients who have headache, just for headache, unless have other clues from history that seizures might be like there. But otherwise, I try to avoid it, because doing EEG for not a good reason, you will stuck with it, okay? You get abnormality and then you stuck with it. You don't know what to do with it, okay?
Yes, it is misleading. I totally agree with you, but we confirm it because young doctors who are not in the field usually get confused from this point. Okay.
Yeah.
Okay, very good. Anyone want to ask about anything else? Because I want to shift to another entity about abdominal migraine. Okay. In many children with recurrent abdominal pain, which is not explained by GIT disease and fulfill criteria for migraine, okay? It gives the same response when we giving analgesic and propranolol as prophylaxis as in common headache and migraine?
Yeah, I think if they have, with abdominal migraine, frequently they can have headache sometimes with these abdominal pains that looks like migraine. So yeah, you can treat them as any migraine, okay? But after excluding other etiologies, okay? So if they have enough workup from GI, if they rule out like kidney stones or metabolic disorders, especially urea cycle, I can present with bouts of vomiting and pain. So then you may consider, and if they are frequent enough, you can give prophylaxis as well, okay? So we can do that. This is entity after, of course, obviously after you rule out other causes.
Clinically, organic causes is very easy to distinguish, but the functional abdominal pain, it is sometimes very difficult to distinguish it is functional abdominal pain or it is abdominal migraine. Usually, we told if the patient during the withdrawal symptom can't tolerate voice, can't tolerate light, has vomiting, it usually go with pain. While if it is associated with diarrhea or not associated with this withdrawal symptom, okay, and the patient not interfere with his ordinary activity, it is more likely to be functional abdominal pain. Are you agree with me in this point for differentiation?
Yeah, I think I agree. Yeah, I think the functional abdominal pain is like similar to tension type headache, okay? And then stress is related to that. And the abdominal pain is not very severe, okay? Usually it's pain, chronic aching. And the migraine,
okay, I hear you.
Pain is usually severe pain, usually. The patient has autonomic changes, vomiting, pallor, okay? All these features that you can see with abdominal migraine, which you don't see usually with the functional abdominal pain or irritable bowel syndrome, they call it.
Yes,
I agree, but I totally agree with you.
Thing in abdominal migraine that it is not associated with headache in many cases.
Yeah, absolutely. Yeah, this is, I mean, by definition, okay? But like only 30% of them, they will have headache with them. But they are the clues for the migraine, like underlying physiology, okay, or pathophysiology. So their presence is like somewhat supportive of the theory of like migraine cause as a cause, because as you know, we don't have markers for or tests for migraine. So presence of the headache with migraine features can be comforting and help you in like confirming the diagnosis.
Yes. Thank you very much for sharing your experience with us, doctor.
Thank you very much. Thank you.
السلام عليكم ورحمة الله وبركاته أستاذ محمد
عليكم
طلال.
السلام. حياك الله أبو محمد.
دكتور محمد هلال، دكتور عايدة، في عندكم أسئلة؟ أنا في عندي أسئلة مشان أعطيكم الفرصة إذا في عندكم أي شيء. ما بعرف إذا الأستاذة مروة في عندها أي شيء كمان.
لا خلاص كفايه كده.
الله يعطيك العافية
يعطيك العافية
عليك
دكتورة
أستاذ
مروة.
فضيل أستاذة
ربنا
مروة.
يكرمك يا دكتور، شكرا لمشاركتك الاكسبيرينس
يخليك.
بتاعتك يا فندم.
حياك الله حياك الله.
Okay, I have many questions, if you don't mind, my dear Prof. Dr. Talal, from our
Okay,
colleagues.
go ahead.
Okay, is fundus examination is mandatory in headache cases or limited to those with suspected increased intracranial pressure?
Well, that's a good question. What I usually prefer that everyone should be able to do the fundus exam himself, and because most of us, we don't have the luxury to have like ophthalmologist close to you that you send the patient to him. So it's better to train yourself to look at the fundus and look for the any features of papilledema. But in general, if the patient has infrequent headaches and the headache looks like the primary headache, then there's no necessity to send for ophthalmology unless the headache is changed in character and it becomes more frequent or more severe. Then I think at this point getting ophthalmology assessment probably is indicated, because sometimes like the pseudotumor cerebri, they can be have mild presentation. So catch them early is we are doing very good favor for the patient.
Okay. The second question: what's about magnesium supplements in prophylaxis of migraine? And another thing, is there any studies which support fasting as a treatment of migraine?
So for the magnesium, I think the studies are only patient studies, not strong evidence, similar to the riboflavin and coenzyme Q. So, but it's considered like treatment in this regard. But many people, they use it as well. And personally, I don't use it because I don't have experience with it, so I don't use it. But it's one of the options. You can use it for prophylaxis. Okay. The second question was
about fasting and its roles about relieving migraine.
I'm not aware. Okay, I know that fasting can provoke migraine in somebody and some people, but as a treatment, I'm not aware. I have to look into this issue. I'm not aware.
Okay. Now my question, I would like to ask you, Prof. Muhammad Talal, about the plan of monitoring and observation of patients with pseudo-tumor intracranial pressure. Okay, how can we observe them in our clinic monthly, 2 monthly? Okay, what the elements or the criteria that guide us to stop treatment? Thanks a lot.
Yeah, you are welcome. I think treatment of pseudotumor cerebri is it has to be with conjunction with our colleagues on ophthalmology. Basically, to initially after the initial phase, usually every month. Okay, we see I see this patient every month and look, and if they are on the improvement curve, so the papilledema is resolving, the headache is resolving, then you can space it to every 2 or 3 months and continue on treatment until the resolution of the papilledema. And then after that, you can start weaning off the medication gradually until discontinue and keep following the patient every 2 to 3 months until 1 year passes without any symptoms or recurrence of the symptoms. And then at that time, I think you can be sure that hopefully it will not come back. There are some cases who came back after like 18 months, but rarely after, it's rare after 1 year of discontinuation of the treatment for recurrence of the pseudotumor cerebri. But this is how we usually monitor. So monitoring is very important, especially from ophthalmology point of view, looking for the visual field, looking for any worsening of vision. If there's any evidence of worsening, then you make your visits shorter, and even admission to the hospital. If the patient has evidence that his vision is deteriorating, then you have to do further interventions, especially adding another drug or resorting to CSF diversion or the optic nerve sheath fenestration, which is something that we don't do, but the CSF diversion LP shunt or VP shunt can be used in those cases who are deteriorating.
Okay. Prof. Talal, I would like to share you one important point from my viewpoint as intensivist, the ICU doctor. In each patient with headache, we have to measure the blood pressure.
Yeah, that's true. I mean, it can be the first sign of the headache can be the sign, the first sign of hypertension. Yeah. Or it can be associated with hypertensive crisis. I mean, for ICU, hypertensive crisis or PRES, okay, posterior reversible encephalopathy. Okay, hypertension is a good player or a main player in those cases. So yes, hypertension is important to look for any patient with headache. I totally agree. Also, I think sometimes we can find multiple factorial issue related to the headache. What I mean, maybe there is many factors contribute headache. Maybe tension headache, migraine headache at the same time. Do you agree? Absolutely, yeah. Frequently, patient has migraine, they can have tension type headache as well. And especially I look into issues related to stress in somebody who does not respond to treatment. So if the patient is on prophylaxis treatment and he's not responding or she's not responding, then you have to look carefully about what's going on with this patient, what kind of stress they are encountering at school or at home. Is there any violence at home? Is there any abuse, verbal or physical bullying at school, mood disorders, depression, all these comorbidities that if they are present, then it makes the response to our treatment and prophylaxis decrease. And then if you resolve them, you have better chance the patient that he will improve or she will improve. Also, what's your opinion about the reflections errors as one cause of headache in children? Yeah, I think we see it frequently. So any patient who have headaches, especially by the end of the day, especially affecting the eyes as well, I usually send them to ophthalmology or optometry to check for any need for glasses. Okay, because it can be a source of headache as well. Yeah, and the treatment is the glasses, in fact. دكتور طلال، في نهاية هذه المحاضرة الأكثر من رائعة، نسأل الله العلي العظيم أن يجعل ما قدمته لنا في ميزان حسناتك. On behalf of all the doctor in our beloved Egypt, we are so grateful to you for your kindness and for your presence, and we hope to promise us in the upcoming future to present another lecture to all of us, I think, about infantile spasm and to give us your experience about this important topic. Thank you so much, Prof. Absolutely, it's my pleasure, and thank you for the invitation, and I'll be happy to share with you my experience on this topic and in the future, inshallah. جزاك الله عنا كل خير وكل شكر محبة لك أستاذ طلال. بارك الله فيك. شكرا دكتور صبري. وأنتم بخير ومصر حبيبة بخير وسوريا بخير ومملكتنا بخير وكل أمتنا العربية الإسلامية بألف خير. شاكر وممتن لحضرتك. احترامي أستاذ. جزاكم الله خير. بارك الله فيكم جميعا ويعطيكم العافية. الله يعافيك. كل الشكر والمحبة. احترامي أستاذ. مع السلامة. مع السلامة. كل الشكر والمحبة. احترامي أستاذ. مع السلامة. مع السلامة. شكرا.